बिस्मिल्लाहिर्रहमानिर्रहीम। रब्बी शरहली सदरी व यस्सिरली अमरी वहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली। अल्लाहुम्मा इन्नी अस्अलुका इल्मन नाफ़िअन रिज़्क़न तय्यिबन व अमलन मुतक़ब्बला शिफ़ा मिन कुल्लि दा। Today we are going to discuss the ovarian cancer, and this is the part 2 of the lecture on ovarian tumors. This is Dr. Zunaira Faiz, and I want to just throw light on the malignant ovarian masses as a part 2 of the lecture. It's a continuity of the part 1, that is part 2 now. Introduction. Accounts for 25% of the gynecological cancers. Ovarian cancers, 27% of the tumors, they are malignant, known as the silent killer. 75% they are diagnosed with advanced disease, have a high mortality rate, 5-year survival 10 to 28%. Normal ovaries. Size 3 into 2 into 1 centimeter. Variations in dimensions can result from endogenous hormonal production, varies with age and menstrual cycle. Exogenous substances include oral contraceptive pill, GnRH agonist, ovulation-inducing agents, etc. Etiology. Believed to be due to irritation of the ovarian surface epithelium by damage during ovulation, increased risk if multiple ovulations, and decreased risk if ovulation suppressed. Nulliparity, increased risk. Early menarche or late menopause, increased risk. Combined oral contraceptive pills, decreased risk, and pregnancy, decreased risk. BRCA mutations. BRCA1 and BRCA2 gene products involved in repair of damaged DNA. Mutations lead to increased risk of ovarian and breast cancer. Hereditary non-neopolposis. Hereditary non-pulposis colorectal cancer syndrome. It was first diagnosed over 100 years ago, and it is the most common of the recognized inherited colorectal cancer syndrome, also called as Lynch 2 syndrome. Identified in families with strong history of the colorectal, uterine, and ovarian cancer. Rare than BRCA, BRCA2 mutations. Lifetime risk of ovarian cancer is 12%. If prophylactic surgery, then consider hysterectomy in addition to the BSO, bilateral salpingo-oophorectomy. Histological classification, we can see the types and subtypes. Epithelial ovarian tumors, 80%, and high-grade serous endometrioid, clear cell, mucinous, low-grade serous, that is borderline. Sex cord stromal tumor, granulosa cells, sertoli Leydig cells, gynandroblastoma, and germ cell tumors 10%, dysgerminoma, endodermal sinus tumor, teratoma, choriocarcinoma, mixed, and metastatic tumors, Kuchenberg's tumor. Histological classification of the ovarian tumor, if we see here in this picture, germ cells, that is the germ cell tumors, includes dysgerminoma, endodermal sinus tumor, embryonal carcinoma, teratoma, other germ cell tumors. Stroma, that is sex cord. Granulosa cell tumor, sertoli Leydig cell tumor, theca cell tumors, fibroma, other includes this stromal cell tumor. Surface epithelium, serous tumor, mucinous tumor, endometrioid tumors, clear cell tumors, transitional cell tumor. Diagrammatic representation of the origin of the ovarian tumors. Epithelial tumors arise from the surface epithelium, germ cell tumor from the germ cell in the ovarian follicles, and sex cord stromal tumor from the stroma of the ovary. Now, this we can see cell of origin. We have the epithelial cells, germ cells, sex cord stromal tumors, germ cell plus sex cord stromal cells. Proportion percentage of the ovarian tumor, proportion percentage of the malignant tumors, age group, and histological types. And if we see this, it is the about 75 to 85% epithelial cells. Proportion of malignancy, again, it is 80 to 90%. Age group is 40 to 65. And you can see adenoma, cyst adenoma, adenocarcinoma, cyst adenocarcinoma, undifferentiated carcinoma, and Brenner cell tumor. Here, germ cell includes dysgerminoma, teratoma, and malignant tumors. Proportion of the tumor, that is 15 to 20%, 2 to 3% is the risk of malignancy, and more than 30 years is the age group. Here, sex cord stromal cell tumor, granulosa cell tumor, theca cell tumor, luteoma, sertoli Leydig cell tumors. 7% is the total ovarian tumors, 1 to 2% risk of malignancy, and 50 years is the age group. Germ cell plus sex cord stromal cells, that is again age group is about 5 years, as you can see, and mixed dysgerminoma and granulosa cell tumor. Epithelial cell tumor, you can differentiate it as the serous cyst adenocarcinoma and mucinous cyst adenocarcinoma. Serous cyst adenocarcinoma, it presents with it is present in the advanced disease involving the ovaries, fallopian tube, and peritoneal surfaces. Most common 75%, most common in 4th and 5th decade of life, bilateral in 50% of the cases. Mucinous cyst adenocarcinoma, 8 to 10% of the epithelial tumor, ovarian tumors, largest ovarian tumors, 5% they are malignant. Bilateral, it is 8 to 10%. Mucinous secreting epithelium, honeycomb appearance, if rupture, may lead to the pseudomyxoma peritonei and adhesions formation. Ovarian cyst adenocarcinoma. You can see it is the gross appearance and it is the on histological appearance. Endometrial tumors, and then is the Brenner and clear cells. Endometrioid tumors, 6 to 8% of the epithelial tumors. Most are unilateral, almost all malignant. 15 to 20% associated with endometrial cancer may have concurrent endometriosis. Again, the other one is the clear cell tumors, clear peg-like or hobnail-like cells. Most clear cells malignant, 50 to 70% they have endometriosis. Brenner tumors resemble internal lining of the urinary bladder, sensitive to the chemotherapy, favorable prognosis. Germ cell tumors, 20 to 25% of all the ovarian cancers. Malignant types, 3%. First 2 decades of the life mostly affected. Rapidly growing. Dysgerminoma, commonest germ cell tumor. Tumor markers raised, that is LDH, ACG, and alpha fetoprotein. Sex cord stromal tumors, 7% of all primary ovarian tumors. As constituent cells are engaged in ovarian hormone production, present with virilization symptoms, hirsutism, acne, irregular periods, male pattern, baldness, and horsewise. Diagnosis. Symptoms. Non-specific wake, 66% present stage 3 or greater, increased abdominal girth and bloating, persistent pelvic and abdominal pain, changes in the bowel habits, irregular bleeding. Symptoms present for less than 1 year and occur on more than 12 days or 12 days per month. Now, here in this picture, you can see how to detect a lump, then hormonal disorders, digestive disorders, loss of appetite and weight loss. In the uterus, you can see the cancer, a normal ovary and the cancer ovary, the differences. Uterus is like this, it is bloated, it is a little bit enlarged, and you can see also the vagina secretions. There can be bleeding, here swollen abdomen, bloating, stomachache, and menstrual disorders. Signs. Fixed heart mass arising from the pelvis, left supraclavicular, virtuous and inguinal lymphadenopathy, ascites, enlarged liver, nodules in the pouch of Douglas, unilateral lower limb edema, varicose veins, and pleural effusion. Investigations. Hematological test. You see full blood count, urea and electrolytes, LFTs, especially albumin. Tumor markers. CA125. In 80% of the epithelial cancers, RMI it is useful for identifying the patients at high risk of cancer and who should be referred to a cancer center for treatment. CEA, carcinoembryonic antigen raised in colorectal cancer, normal in ovarian cancer. Tumor markers for rare ovarian tumors, if appropriate, alpha-fetoprotein, ACG, LDH inhibin, and estradiol. RMI, it is the product of ultrasound scan score, the menopausal status, and the serum CA125. The ultrasound result is scored 1 point for each of following characteristics: multilocular cyst, solid area, metastasis, ascites, and bilateral lesions. So it is the risk of malignancy index, which is called RMI. Here you can see in tumor markers, RMI useful for identifying patient at high risk of cancer who should be referred to a cancer center for treatment. Investigations. Again, imaging, that is abdominal and pelvic ultrasound, present with the presence of the pelvic mass and ascites recommended by NICE guidelines if CA125 raised. Chest X-ray, pleural effusion or the lung metastasis for staging and preoperative workup. CT abdomen, pelvis, omental caking, peritoneal implants, liver metastasis, para-aortic lymph nodes. Tumor markers. Again, as we see here, CA125, CA19-9, inhibin, ACH, alpha-fetoprotein. Tumor types and the uses, if you see again, CA125, the pelvic and epithelial tumors, cancer, serous, borderline, and ovarian tumor, and it is useful in the follow-up. And CA19-9, epithelial ovarian cancer, especially the mucinous, borderline, and ovarian tumors, preoperative follow-up. Inhibin, granular cell tumor and follow-up, and ACH, that is dysgerminoma, choriocarcinoma, preoperative follow-up, and alpha-fetoprotein, endodermal yolk sac teratoma, preoperative follow-up. FIGO staging of ovarian cancer. Stage FIGO definition. Stage 1, 1A, 1B, 1C. And this we can see stage 1A, in which stage 1 actually it is confined to the ovary. When we subclassify, when we see in detail, that is stage 1A limited to one ovary, stage 1B limited to both ovaries, capsule intact, no ascites. Stage 1C, 1A, 1B plus ascites containing malignant cells. In stage 2, 2A, B, C, 2A, extension to the uterus and tubes. Stage 2B, extension to other pelvic organs. Stage 2C, 2A, 2B plus ascites containing malignant cells. FIGO staging of the ovarian cancer, that is stage 3, that is 3A, B, C. In stage 3, intraperitoneal metastasis outside the pelvis. Stage 3A, histological microscopic peritoneal implants, and stage 3B, that is abdominal implants less than 2 cm in diameter, and stage 3C, abdominal implants more than 2 cm in diameter or positive retroperitoneal inguinal lymph nodes. Stage 4, that is distant metastasis. Here in this picture you can say stages of the ovarian cancer. 1A, here in the one ovary. 2A, you can see the lesions in the red color. 3A, again it is in the ovaries, in the uterus, in the vagina, not only the vagina, also in the intestines, around the pelvis you see here. And here in the 1A, B, C, if you go in this side, 1 ovary, 2 ovary, and 3 ovary. 2A, again you can see B, A, B, and C, and 3A, again it is spreading in the around in the pelvis, around the uterus and ovaries. Spread, direct spread, tube, uterus, bladder, pelvic peritoneum. Lymphatic spread, pelvic and para-aortic lymph nodes. Blood-borne, liver, lung, bone, brain. Transcoelomic spread, that is peritoneum, liver, and diaphragm. Management. Patients with a high RMI is equal or greater than staging laparotomy to be performed through a midline incision, ideally a cancer center by a gynecological oncologist. The laparotomy should aim to remove as much tumor as possible. Achievement of the optimal debulking is a positive prognostic factor Full staging in stage 1A cancer is important as this affects whether adjuvant chemotherapy is required. Management. Surgical MDT involvement. That is stage 1. Staging laparotomy includes laparotomy, hysterectomy, bilateral salpingo-oophorectomy, omentectomy, lymph node sampling, that is pelvic and para-aortic, peritoneal biopsies, pelvic washings and ascitic sampling, young patient fertility sparing surgery after frozen section. Stage 2 and stage 3, staging laparotomy, post-op chemotherapy, radiotherapy. Stage 4, palliative chemotherapy. Adjuvant chemotherapy. Adjuvant chemotherapy following surgery is recommended for all patients other than those with low-risk early-stage diseases. Stage 1A, B, low-grade disease. For advanced disease, stage 2 and greater, randomized controlled trials have demonstrated that platinum agents, they are superior and than that of the carboplatin. That is, carboplatin is equal to cisplatin in terms of prognosis but has less side effects. Prognostic factors: stage of disease, volume of the residual disease, post-surgical, histological types and grade of tumors, age at presentation. Survival. FIGO classification: 5 years survival, it is 80 to 90%, stage 1, stage 2 65 to 70%, stage 3 30 to 50%, stage 4 is 15%. Ovarian cancer awareness. When we talk about its awareness, the 4 primary symptoms of the ovarian cancers are: number 1, bloating, pelvic or abdominal pain, difficulty eating or feeling full too quickly, and last but not the least, urinary urgency or frequency. With this, I end with this lecture and hope this lecture will freshen your knowledge. Jazakallah khairan.